call upon Father Abhijit for prayers.
പ്രാർത്ഥനയോടുകൂടി നമുക്ക് ഇന്നത്തെ പ്രോഗ്രാം ആരംഭിക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധ റൂഹായിക്കും സ്തുതി, ആദ്യം മുതൽ എന്നേക്കും തന്നെ ആമേൻ. ഞങ്ങൾ അതിവാത്സല്യമായി സ്നേഹിക്കുന്ന ദൈവമേ, സ്വർഗസ്ഥ പിതാവേ, ഞങ്ങൾക്ക് ഒരുമിച്ച് ഇന്ന് ഈ പ്രഭാതത്തിൽ ഇവിടെ കടന്നു വരുവാനും ഞങ്ങൾ കർത്താവ് ഹോസ്പിറ്റലിൻ്റെ കീഴിൽ നടത്തപ്പെടുന്ന പ്രോഗ്രാമുകളൊക്കെ ഭാഗമായി തീരുവാനും ദൈവം തമ്പുരാൻ ഞങ്ങൾക്ക് നൽകുന്ന നല്ല നന്മകൾക്കായി, അവസരങ്ങൾക്കായി നന്ദിയോടെ സ്തോത്രം ചെയ്യുന്നു. പ്രത്യേകിച്ച് ഈ പ്രഭാതത്തിലൂടെ നടക്കുന്ന പ്രോഗ്രാം ഞങ്ങളുടെ കരങ്ങളിലേക്ക് ഏൽപ്പിച്ച് പ്രാർത്ഥിക്കുന്നു. അത് ഞങ്ങളുടെ ഹോസ്പിറ്റലിൽ പ്രവർത്തിക്കുന്ന എല്ലാവർക്കും ഏറ്റവും അനുഗ്രഹമായി തീരുവാൻ അവിടുന്ന് സഹായിക്കണമേ. ഈ പ്രോഗ്രാമിന് ആവശ്യമായ നേതൃത്വം നൽകുന്ന പ്രിയപ്പെട്ടവർ, ഞങ്ങളുടെ ഹോസ്പിറ്റലിലെ മാനേജ്മെൻറ്റ് അംഗങ്ങൾ, മറ്റു ഡോക്ടർമാർ എല്ലാവരെയും ഞങ്ങളുടെ കരങ്ങളിലേക്ക് സമർപ്പിച്ച് പ്രാർത്ഥിക്കുന്നു. ഞങ്ങളത് കർത്താവ് ഞങ്ങളുടെ ജീവിതത്തിൽ മാത്രമല്ല, ഞങ്ങൾ കേൾക്കുന്ന കാര്യങ്ങൾ, ഞങ്ങൾ പഠിക്കുന്ന കാര്യങ്ങൾ, ഞങ്ങൾ മനസ്സിലാക്കുന്ന കാര്യങ്ങൾ, അത് മറ്റുള്ളവരിലേക്ക് പങ്കുവയ്ക്കുവാനും അത് മറ്റുള്ളവരുടെ ജീവിതത്തിന് ഉപകാരമായി തീരുവാനും അവിടെ ഇടയാക്കി തീർക്കണമേ. ഈ ഡിപ്പാർട്ട്മെൻറ്റായി ഞങ്ങൾ പ്രാർത്ഥിക്കുന്നു. ഈ നാളൊക്കെയും കർത്താവ് മികച്ച രീതിയിൽ ഞങ്ങളുടെ ഹോസ്പിറ്റലിൽ പ്രവർത്തിക്കുവാൻ അവരവിടുന്ന് സഹായിക്കുന്ന കൃപകൾക്കായി നന്ദിയോടെ സ്തോത്രം ചെയ്യുന്നു. ഗസ്റ്റായിട്ട് കടന്നു വന്നിരിക്കുന്നവരെ നിൻ്റെ കരങ്ങളിലേക്ക് ഞങ്ങൾ സമർപ്പിക്കുന്നു. അവർ ചെയ്യുന്നതായിട്ടുള്ള ക്ലാസ്സുകൾ, അവർ പറയുന്ന കാര്യങ്ങളൊക്കെയും എല്ലാവർക്കും ഹൃദയസ്ഥമായി തീരുവാൻ അവിടുന്ന് സഹായിക്കണമേ. ഇനി തുടർന്നുള്ള സമയങ്ങൾ ഇവിടെ കടന്നു വരുന്നവരെല്ലാം നിൻ്റെ കരങ്ങളിലേക്ക് സമർപ്പിച്ച് പ്രാർത്ഥിക്കുന്നു. ഈ ദിവസവും തുടർന്നുള്ള സമയങ്ങളും ദൈവം തമ്പുരാൻ അനുഗ്രഹിക്കുകയും വഴി നടത്തുകയും ചെയ്യണം. ഞങ്ങളുടെ പ്രാർത്ഥനയും യാചനയും കേട്ടതിന് നന്ദി. യേശു ക്രിസ്തുവിൻ തന്നെയുള്ള നാമത്തിൽ തന്നെ ആമേൻ. എല്ലാവർക്കും ഇരിക്കാം.
I now invite Dr. Sujit Philip, HOD and Senior Consultant Gastrosurgery, to moderate the session.
Good morning all. Being a surgeon, after surgery we have to write the postoperative orders. So when we write the postoperative orders, it is usually we'll write the IV fluids, we write antibiotics essential, IV fluids essential, some PPI, then we write NPO. We don't care about the nutrition as a patient, we'll keep them starving. So what we realized over the years is that as antibiotics and IV fluids are essential, nutrition is also an essential part of the patient recovery. That is one thing which I realized over the past 10-15 years. So we nowadays what we do is this NPO. NPO means nil per hourly, but we now turn to nutrition as early as possible. This has to take into account ILS, but the idea, the paradigm shift that has occurred is to start nutrition as early as possible. And with this in view, actually in our hospital, actually we are fortunate to have a very good ERAS program. ERAS is Enhanced Recovery After Surgery. ERAS. It's an European concept, but now it's applied all over the world. And so that involves. So when a patient comes here for a major surgery, what happens is that when we send them for the preoperative workup to the anesthetist, it's not just the anesthetist. Two other departments are actively involved. One is the physiotherapy department, who encourages the patient to do physiotherapy so that his muscle power is better. And equally important is the dietetics department. So they assess the patient nutritionally, and then we put them on a diet, an individualized diet based on their nutritional requirements. And so what we seen is that though we don't live in that economically poor area, many of the patients, since they are major surgeries and they would have malignancies, they are nutritionally depleted and they require some rehabilitation before surgery. And that might require postponing the surgery by around 7 to 10 days. Thankfully, most patients do agree to that. They realize the importance of building them up nutritionally. And so for that, we are so fortunate to have a very active nutrition department of dietetics headed by Dr. Jyoti, and thanks to the management who is so supportive of the nutrition department. Because when we speak about a stewardship program, a nutrition stewardship program, it is as important as antibiotic stewardship program. That is what we realize. Antibiotic stewardship program is big in many hospitals, but what we realize that nutrition stewardship program is also important. And that has three departments involved in nutrition stewardship program: the clinician, the management, and the dietetics department. All the three play a very important role. And so that's why, that's one of the reasons that we have this quest. And for that, actually, to enlighten us about a paradigm shift in nutrition critically ill patients, we have the critical head also here, who is also very pro in starting enteral nutrition as soon as possible. And so to enlighten us on this, and for inauguration of our NSP, Nutrition Stewardship Program, we have with us Dr. S Vijayanand. We are so thankful for, sir, to have you in our midst. And he is the director and clinical lead of emergency and clinical and critical care medicine in Devagi Hospital, Madurai. And he's basically an anesthetist. He did it ID, CCM, and then he did his PDCC from CMC Vellore, and then did his EDIC from UK. And on behalf of all of us, I welcome you, sir, for a talk.
Thank you so much for the introduction, sir. Hope it is early morning and you all must have had your breakfast, right? So the next 40 minutes I'll be running you through the concept of nutrition. How far is working? How to go back? Okay. Is backward? Okay. So once again, a very good morning. So for the next 40 minutes, I'll be making you to understand the concept of what has happened with regards to nutrition in critical ill patient and how far you can take the nutrition in your post-operative wards as well as those patients who are electively posted for surgery. So this is a newer topic. Actually, I gave this talk around 3 months back in the IMA for, not for an IMA, it's a medicine associate. After 40 minutes, they were looking at me, what is this new concept on nutrition? So that is where we are still. We are still wondering whether we can go ahead with the nutrition or not. So thank you so much for inviting me here and having it your beautiful city of Tiruvalla. And to begin with, I have nothing to disclaim. So except that I'm an anesthetist by background. So I work in an ICU and take care of a critical ill patient. So begin with what is the role of an intensivist? We all think that intensivist is just taking care of your critical ill patient, and we see that, okay, intensivist has a role to look at your ventilators, taking care of your hemodynamics, taking care of blood pressures, vasopressors, catheterization. That is what we all think, right? That is a common notion about an intensivist. Do you know what is the role of exactly the role of an intensivist in ICU? It is like an United Nations General. See, what the United Nations General does is, he is capable of keeping the peace among the countries, right? That is the same way when a patient comes to an ICU, you have a patient with organ failure, and these organs have cross-talking. So they are fighting among each other. So the purpose of having a intensivist in the ICU is to make the organs behave peacefully among each other. At the same time, have a cordial relation with the other consultants, a nephrologist, a patient might be another nephrologist, and the patient might have a cardiac syndrome, and the cardiologist, and they have to take the communication between all the people and make sure it smooth functioning inside the ICU. That is the main concept of an intensivist working in ICU. In addition to that, they are also responsible for managing the nutritional part. Many of what happens when you have a fever for 2 or 3 days? What do? You cut down your intake, right? As soon as you have a fever, you cut down, you start taking some porridge, you reduce your water intake. Similarly, a patient who had traveled to a recent place and has come back to a city, has got an infection, he has got a lung infection to the lung. Immediately, for the first 2 days, you start reducing your intake. That is the most important thing you'll do. Instead of, you will take some paracetamol, you will take some antibiotics from the recent from your nearby pharmacy. But the first thing they'll do is cut down the nutrition. It's the same patient who becomes sick. The lung infection becomes more, he ends up in a ventilator, he comes to us. By the time he comes to us, he has reduced his nutrition, he has already gone from anabolism to catabolism. That is the main concept of a nutritional pathway. So when you think of a quality of ICU care, these are the qualities which we always look at. How many days my patient is staying in the ICU, how many days the patient stays on the ventilator, and am I able to cut down my infection? Because most of the time your patients will have a central line, your patients have an arterial line, you may have a catheter, you may have an endotracheal tube. All these are like an pathway for infection. So we try to do to reduce the infection. And we try to assert what has happened to my patient after 30 days, whether my patient is alive after 30 days or not, and if my patient is alive after 90 days or not. These are the major things what we do, what picks up the quality of an ICU care. In that, very important concept is, have I recorded the nutrition part of the ICU patient or not? That is the most important answer. So, as I already told you, so first itself, the patient pre-admission illness, because of his illness, he is not taking proper intake. He has already gone into pre-critical illness. And by the time he comes to an ICU or he goes on ventilation, he has got an acute phase of critical illness, and which becomes a chronic critical illness within 14 days of ICU. He stays in ICU for 10 to 14 days. From acute phase, he goes in a chronic phase. He somehow gets extubated, somehow it comes out the infection, he gets shifted to the ward. But he will be in the ward, he'll be having an early phase of recovery. Then, once he goes back to the home, he will be having the post-hospital discharge for long-term therapy. This is what happens. So when you don't look at the nutrition part in the pre-critical illness, the first part itself, or the patient comes to an ICU, you don't take care of the nutrition part. Obviously, the changes, what is going to happen in the ward or what is going to happen in his home is going to be robustic. It's like a roller coaster ride. He will be having a multiple comorbidities happening to him at the time. So the concept is, yes, nutrition is very important in a critical ill patient, especially what Sir has told you about the enhanced recovery after surgery. That is the ERAS protocol. All the patients going for any malignancy patient going for surgery, it is mandatory. You have to take care of the nutrition. So I'm not saying that you feed this patient this kind of materials so that I keep the patient energetic. There are specific protocols, specific calories and protein which has to be given to the patient. Let me start with the case. This is a real case, okay? Actually, a 57-year-old male, he has got a history of chest comfort for 3 days. He comes to the casualty with the complaints of breathing difficulties, increased sputum production, and he has a past medical history of diabetes and hypertension and alcoholism. And the past 3 days, he didn't have consume any alcohols. Over the past 2 months, he has been taking alcohol on and off, so he has got a reduction in his body weight. About 8 to 10 kg of body loss has been there, and there was no past medical history and surgical histories. And on patient examination was diaphoretic, he was very anxious, he was sweating, diaphoretic, and I could see he was having a JVP was elevated. And the bitemporal, because of the muscle loss, he had lost all the muscles on the bitemporal radius, and there was a lot of wasting. And because he was in a hypolemic shock, he was cold, clammy skin was present. And auscultation showed me that he has got some kind of lung infection. And his BP was around 110 by, heart rate was 110, BP was around 90 by 40, rate of around 28, a classical community pneumonia, and saturation was 84 and room air. So this was his initial presentation. When we tried to do that, his count to present was 19,500 to begin with. His electrolytes was always on the lower side, creat has gone up to 2.8, and ABG showed an acidosis with a PCO of 40 and a PA of 76. And this patient was requiring 10 liters of oxygen. So this is a classical patient who has come to your emergency and patient ends up in your ICU. This is the classical patient. He has been consuming alcohol and he has brought a lot of weight, and now he has come to us with a respiratory infection. So what are the questions we need to? I'm not going to talk about what is the ventilatory management, what you're going to do with the vasopressors, or going to use anatropes or your antibiotics. The question we need to answer is, what is the role of nutrition in a critical ill patient ICU? And how you will assess the nutritional risk in this patient? What will be the nutrition management strategy? These are the 3 questions which we need to answer along with your ventilative settings, your inotropes, vasopressors, inotropes, your antibiotics, catheterization, central line, everything's along with this has to be done. This is the take-home message. So as I already told you, as initial days, as this patient has come to us, within 1 day, he will have something called as F phase. The patient is gone in a shocky stage. And after 2 to 7 days in the ICU, he will be having something called an early flow phase, where the patient has gone from catabolism, gone into a catabolic phase. And after 7 to 14 days, what is going to happen is you are going to have flow phase. There is an early flow phase as well as a late flow phase. Obviously, the patient is going into an anabolism. So what is going to happen is, on the first day, what we will be doing is, we will be trying to manage the patient in shock. We try to do every component what we can do for the patient. For the next 3 to 7 days, what is going to happen is, he is going to be in the recovery stage, and after 7 to 14 days goes into the ward and goes into the home. So what has happened is, if you don't address during this first 2 to 7 days, obviously the nutritional part is going to come down. Obviously the patient recovery is going to be a roller coaster. So that is what the main common. So what do you mean by the F phase and what do you mean the flow phase is? So as I already told you, F phase occurs within the short period of time. So what is going to happen is the metabolic requirement is going to go down and the body try to restore its tissue perfection. Obviously, a patient coming in a shock to your hospital is basically the main pathology is the tissues have stopped taking oxygen from the cardiac outputs. So basically, the impaired tissue oxygenation is one of the major components of any patient coming with the sepsis or trauma. So that is what we are going to see in the first 1 to 2 days. And during the flow phase, what is going to happen is there is a catabolic phase and the patient is going to have hypermetabolism. The fluid is starting to get into the body, they are going to become boggy, and protein and fat immobilization will start happening. And what is going to happen is the weight loss begins to happen. So a patient who has already had 8 to 10 days of weight loss before coming to the casualty or your ICU, after coming to the ICU, because of improper nutrition management, what is going to happen is, again, there's a drop is going to happen with all your weight, body weight. Ultimately, the end of it will be an anabolic phase where the weight gain will start gradually, but he may take up to 6 months of coming out of the initial trauma. So what the concept is, if you don't take care of the nutrition part within 7 days, in addition to other components, you're ultimately going to have this component of therapies. So F phase is 24 hours. What is going to happen is there is going to be a decreased metabolic response. The temperature is going to go down, the oxygen consumption is going down, because to maintain the tissue perfection, there's going to be an increased cardiac output, vasoconstriction is going to go high, there will be increase in heart rate, and there will be increase in acute phase reactant. This is first classically what you do on the first day. So basically, most common hormones involved is catecholamines, cortisol, and aldosterone. Over the next 3 to 10 days, the body tries to maintain this energy. Somehow, it tries to increase the BMR, increase the temperature, try to increase the oxygen consumption, goes into an acute energy balance, and try to say that, okay, since you are not feeding me, I will try to feed myself. That is what is going to happen. The hormones going to increases, the glucagon and the insulin going to go high, the cortisols and catecholamine resistance will also go high, and ultimately we'll have something called insulin resistant. The anabolic phase, which runs up to 10 to 10 days, basically whatever the tissues you are lost in the ICU because of improper nutrition management, the body is trying to recover. This is the classical pathology. So as I already told you, a critical ill patient, maybe because of a shock, like what I told you, a patient with a lung infection, patient with a sepsis or trauma. And ultimately, what you try to do, any type of patient with a shock, we try to stabilize. What I told you is a tissue oxygen extraction is going to be less. So we try to ventilate the patient. Patient might have some kind of like inflammatory response will be there. You'll be giving a lot of medications like neuromuscular blockade will be there. You'll be giving vasopressors, steroids will be induced, sedations will be given. And ultimately, you are going to give inadequate protein and calories. Is the marker seen over here? This is not seen, right? Okay. So ultimately, if you are not going to feed the patient properly, they are going to have a protein and calorie delivery is going to less. Now ultimately, the patient will have a lean body mass muscle and they will reduce to physical. This is one of the most important factor indicated why the patient is not recovering after a critical therapy. So why we need this kind of therapy for nutrition therapy in critical patients? Because these are the data. About 30 to 50% of the patients who are getting admitted into the hospitals are already malnourished. Because of some inherent properties, they are already malnourished. By the time they stay in the hospital, 33% of the severely malnourished patients and 38% of the malnourished patients experience a nutrition deficiency. So you don't take care of the nutrition, obviously over the 3 to 7 days, they are further going to drop going to have the malnutrition. So ultimately, by the time they get discharged, either they go to the ward or they go to the home, they are going to have continuous weight loss. And that is one of the reasons why this patient come back to us for readmission. So most of your patient who comes for any surgeries, any bigger surgeries, any Whipple's, or a patient coming for a CS stomach, going for a gastrostomy, or going for a bypass surgeries, almost all of these patients are malnourished. You are not going to address to this, and this is one of the major factors which is going to make them come back to your hospital again. So it's a very famous Hippocrates oath. Basically what's it saying? A slender and restricted diet is always very dangerous in chronic as well as in acute doses. So patient with malignancy, obviously they are going to reduce their intake, obviously they are going to come back to your hospital again. So how do I figure it out? What should I do? So we know the pathophysiology, we know what is going to happen to the patient, how to go ahead with the nutrition therapy in our ICU. So how do you figure out? All the patients are not created equally, right? We may have a patient with 40 kg, I may have a patient with 100 kg, I may have a patient with 80 kg. So all these therapies will not be suffixed to each patient. So we have to individualize the nutrition therapy personal to each patient. And you should not expect the patients to respond in the same way to all the nutrition therapy. So one patient who is with 40 kg will respond very fast, and the other patient who is 100 kg will not respond very fast. So it has to be tailored to individual to each patient. So what is the first thing we are to doing to this? Are we going to feed the patient based on the real body weight, or are we going to feed the patient on the ideal body weight? So when we are going to feed the patient on the ideal body weight, obviously the patient is underfed. You are not going to give the adequate nutrition for the patient. And similarly, in a patient whom you are going to give based on the real body weight, I may have a chance of overfeeding, and ultimately, because of the catabolism, the patient will become boggy. I may have a difficulty in taking over the ventilators, so I may have a difficulty in making walk again. So, and also, whenever the patient is obese, you are going to have a glucose intolerance, and in those conditions, the patient is in a stress, it gets worsened. So ultimately, what is the choice? Whether I should go with the real body weight, or should go and check the ideal body weight using inch tape, or should I use something called as adjusted body weight? The basically adjusted body is a formula is you go and calculate the ideal body weight, and you make the difference between ideal and real body weight, add by a point into 0.4, it will give you the weight based on which you are going to give the nutrition therapy. This is the first thing we'll be doing for any nutrition patient. Next question to ask ourselves is when to start the feeding. Second thing, almost every day in your rounds or every day in your patient who's going to be in your ward or patient with a post-malignancy surgery, you have to ask ourselves whether can I start the feeding today itself. Second thing is which product to choose from. There are multiple scientific products available, protein formulas available, which one to choose from. How I'm going to calculate the energy and protein. These are the basic things we have to do. Any role of immune modulation drugs, should I use continuously, like I have seen people giving a bolus. Every time, every 1 hour, they go and push a feed into the patient. Should I use a continuous or a bolus therapy? What will happen if there is a high gas? The patient is not putting out, and he's going to have a volume of vomiting going to happen. If the gastric residual volume is good high, should I how to address to it? Can I use a prokinetic? Can I use a probiotic? These are the questions which we need to answer every time when you go and see a patient in an ICU or in a post-operative ward. So what I said, first we go by the ideal body weight or by the real body weight. We go by the AB, the average body weight. And then we use something called a scoring system. We have got a lot of scoring system to tell us, yes, this patient is highly malnourished. Straight away start your nutrition therapy. Otherwise, this patient will end up having a rehabilitation therapy. There are a lot of scores like the Nutri-Score, Must-Score, NRS. And there is one more something called as a subjective global assessment. It's all available online. So whichever it's comfortable, you can use it. But our patients are almost sick. We may not have enough time to go and see all these things. That's a part of the dietitian. They come and do this concept and tell us, yes, this patient is malnourished. At the earliest, start the nutrition therapy. This is one of the easiest score which we do it in the ICU, the Nutri-Score. Based on the age, Apache score, SOFA is a sequential organ failure assessment score. Based on that, a number of comorbidities, how many days he has been in the hospital to the ICU admission, and you can use interleukin 6, which has become very common after your COVID therapy. Based on this, there is a scoring system. If you are going to have a score of 6 to 10, obviously, it is going to tell us this patient has got a high mortality if you are not going to give the adequate nutrition therapy at the earliest. If the score is below less than 5, obviously, these patients have low malnutrition risk, and yes, we can wait for some more time. So this is one of the classical score. Now they are using the subjective global assessment, the GLIM score has come, the MUST score has come. Whichever your team is comfortable, you can use it because you have to train every one of them regarding the scoring. So this was one of the earliest article to come in. Basically, they were trying to look at whether my Nutri-Score, which I showed you, is helpful to determine whether my patient has got a high mortality or not. It was a multi-institutional study. More than 600 patients are taken. And they were looking at the intake, historical peroral intake as well as weight loss in 171 patients. And they were looking at whether my patient was alive on the 28 days or my patient was out of the ventilator. This is the quality of an ICU. Whether my patient has come out of the ventilator, my patient has gone home, my patient has recovered from the illness. So they were looking at whether this scoring system is helpful or not. What they found was, as you can see, the observed score, this yellow color, is whenever the Nutri-Score of more than 10, obviously the mortality, mechanical ventilator stay has been more than 14 days. So this score will help us to understand my patient is going to stay for longer time on a ventilator or not. So if I go and calculate for a patient, the Nutri-Score is coming around 8, I know this patient is going to stay for a longer time. It will be easier for me to go and talk to the relatives. Yes, this patient has got malnutrition risk, he has not been properly fed, so this patient can stay in a ventilator for a very long time. This was first thing to tell us. And second thing, they were looking at the mortality. And what they found was higher the score, higher was the mortality. Look at it, the Nutri-score of 10, obviously we have a mortality of 80%. I can go and tell to my patient, this patient is sick. In addition to this, because of malnutrition, he is not going to recover very fast. He may stay in a ventilator for a longer time, and he may succumb to the illness on the 10th day also. So it helps us to tell us. So in addition to by our clinical judgment, we say, yes, this patient is sick. There are a lot of tools to tell us, understand, yes, my patient is going to sick and we're going to die because of your malnutrition. So first thing has been, calculate your ideal average body weight. Second, you can use any of this scoring to determine what amount of nutrition has to be given to the patient. Next, the problem is, what should I do? Should I give the orally or should I start with the IV line and start with the total parenteral nutrition? That is the next question we'll always wonder. So if you look at it, there are two therapies, enteral and parenteral nutrition. Which one to choose for my patient? And these are the ASPEN stands for American Society of Parenteral and Enteral Nutrition, the Canadian group, and as well as ASPEN. All of them suggest the route of feeding should be enteral. You have to try to get the gut to get into action. So almost all the guidelines are saying that straight go for enteral nutrition. Do not go for a total parenteral nutrition. There are guidelines to say that almost all the groups, and in addition to that, the Australian groups as well as the Indian Society of Critical Medicine, all of them are saying that you have to go for an enteral nutrition therapy instead of a parenteral nutrition therapy. So that is the second take-home message. And the preferred nutrition is enteral. Second thing, most of us will go and check the bowel sounds, right? We always say that, yes, my bowel sound is there or not. It is not mandatory. You don't have to check for a bowel sound before starting enteral nutrition. And always remember, it is safe to feed to the stomach. And think of your risk of aspiration. The patient might fail to tolerate. He may have a regurgitation of fluid mass there. That may be in the past also. Patient got admitted in a previously for another procedure. He had this risk of aspiration also there. You keep in that mind, and then you start enteral nutrition. So, and if the patient is sick, if the patient is recurring high vasopressors, then you wait for some time until the patient vasopressors suppose come down, then you start with the enteral therapy. So second take-home message is always it's enteral nutrition, not your total parenteral nutrition. So the guideline says you have to, this is ASPEN and Canadian says start your enteral nutrition within 24 to 48 hours. The ASPEN's European and the Society of Critical Care Medicine of America says 24 to 48 hours. And Australian groups they are very proactive. They start the nutrition within 24 hours. So these are the guidelines. So almost all the countries who are very good, very advanced in their clinical therapies have suggested that within 48 hours you have to start your therapy. So as per the guidelines, you are going to do better thing. So what are the benefits? If you are going to start my nutrition within 24 to 40 hours, what you're doing is, it was a retrospective analysis where patients who are there in ventilator for more than 2 days, around 4,000 patients are taken concern, and they were started with early enteral nutrition. What they found was the hospital mortality was higher in those patients who were started nutrition after 48 hours. So again, it is emphasizing that try to start your enteral nutrition within 48 hours. And in addition to that, it also shows the percentage of survival. You can see that the lower curve is the late feeding, the upper curve is the early feeding. Those patients who had early feeding within 48 hours, they had a higher risk of survival. Again, emphasizing the point that nutrition, in addition to the mechanical ventilation, as in addition to norepinephrine, adrenaline, vasopressin, plays a very important role in determining the outcome of the patient. And this was a very interesting article. Basically, it was a randomized, it was a systematic meta-analysis. They were looking at all the articles come in the with regards to nutrition. They were trying to search whether enteral nutrition earlier is going to be helpful or not. So what they found was, this was around, they were looking at the mortality, they were looking at the infection, they were looking at the length of stay, they were looking at the mechanical ventilation days. What they found was, almost all the patients who were fed earlier within 48 hours, the length of stay was less, the number of mortality came down, as most of the comments, the ventilator, the patient was of infections. The personal infection with the early feeding was lesser when compared to the late feeding. So all the meta-analysis also showing that early feeding is very important when it comes to treating a patient with critical patient. Second thing is, this is a very old article, 2005, where they showed us if you don't give adequate calories during the first, you can see the lower, the x-axis is your days and the y-axis is your kilocals. For initial 5 days, if you are not going to give, if you are going to give a low calorie, and this is the upper curve is your adequate calorie. And obviously what is going to happen is the patient is going to have something called as calorie debt. And that calorie debt is going to produce something called as increased strength of ICU stay, increased day in mechanical ventilation, increased associated complications of mortality. This was an old study where everybody was fed 25 kilocalories. As soon as the patient comes to ICU sick, they'll start with 25 kilocalorie and 2 grams of or 1.5 gram of protein. This was old study. Then we started following this. Okay, as soon as the patient comes in, we have to give the maximum calorie to the patient, maximum protein to the patient. Then this was a study which came in 2011. They were looking at the tropic feed. The tropic feeding was, the total calories which was calculated was only 1,500 kilocalories. They gave only half, 750 on the first day. Second day they gradually went up to 1,000. The third day they increased. What they found was, this is the total energy intake as well as the total amount of calories which was given to the patient. What they found was, those patients who were given lesser feed survived better. Instead of giving 1,500 kilo just like that on the first day or 2,000 kilo on the first day, what they found was the lower calories, and then you gradually go up on the calories, the patient survived better. This was the trial to tell us, yes, we have been treating wrongly. We have to go to the lower calorie strategy to recover the patient. So then there was one study which came in 2007. They were looking at the point prevalence, and they were looking at patients, around 2,000 patients in 155 ICUs over 5 continents. And all these patients were mechanical ventilated more than 72 hours. What they found was, this study showed us, whenever you have, based on the body mass index, lower calories produced high mortality. Again, we were confused. So one study is showing that higher calories produces better outcome. One study is showing that lower calories produce a higher outcome. So we were again confused. What should we do? See, all the body mass based on the 20, if the BMS less than 20, BMS 20, all of them, when the calories are less than 500, the mortality is very high. So we needed something to tell us, yes, what should I do? Should I give a full calorie or should I give a less calorie? So with this study, which came recently, is a Nutria trial. Basically, this is a very big trial where, I don't know whether you're able to see that. They were given 2 groups, the low group as well as the standard group. The low group had a lower calorie. Look at the calories, only 6 calories per kg per day, where the standard group had 25 kilocalories. I don't know whether. The standard group had 25 kilocalories, and they were daily evaluated. And they were looking at, these are the primary outcomes they're looking at. The primary outcome was 90 days mortality. Another outcome was readiness to discharge from ICU. What they found was, there was no difference in the mortality. Whether you give low calories or high calories, the patient, there was no mortality difference. But the patients who were given low calories, they were ready for discharge very early. You can look at the p-value is 0.015. So again, this study, a very big study, which showed us that you give lesser calories to begin with, then they gradually build up the calorie, then you go to the full calories. Again, they were looking at the secondary outcome. Most important was, the rate of infection was also very less. The rate of ventilator association of pneumonia was also very less. And most important, the amount of gastric residual volume, vomiting, everything was very less. This is a big trial to tell us, you start slowly, lower calories, then gradually build up, so that you will have a better outcome, especially the patient gets home very early. The same thing as I showed here. So one thing is, with regards to calories, we had an idea, 25 kilocalorie per kg per day, every day should be given to the patient. That is wrong. We go gradually. You can start with 6 to 10 millicalories per kg. Then you gradually increase on the calorie. That was the first thing. Second thing is looking at the protein. What was the effect of using lower protein versus higher protein? Basically, the protein requirement as per the recommendation of the guidelines is around 1.5 to 2 kilocalories based on the septicemia of the trauma patients. What they're trying to do is, they gave a lower protein for a patient and higher protein for a patient. So what they found was, that study also favored a lower protein. So the take-home message is, start the early enteral nutrition within 48 hours and do not feed the patient with a high calorie diet. Gradually increase on the calories and as well as the protein, so that the mortality benefit is definitely there. So now at 2015 we used to say, give more feed, let the patient come out. At 2025 we are saying, lesser to start with and earlier is better. And if you feed them better, they will leave sooner from your hospital. So concept is very clear. So next, we are all bothered about, should I put an NG tube or should I put in a FJ tube and feed the patient? That is the most common thing we all think. All the surgeons, especially post a patient who has gone up Whipple surgery, gastrectomy, they prefer to give up FJ feeding. So the concept is, we all think that when we put an FJ and we start feeding the patient, there is a decreased risk of aspiration. The gastric secretion is also very less. It improves the nutrition delivery to the patient. And it is commonly recommended if you start before giving a parenteral nutrition. But we needed a guidance. We not to know what is happening inside. This was a multi-center trial. What it found was, there is no need to give FJ feed. If the patient is tolerating a gastric feed, if NG tube, you just give through the NG tube. There are only those conditions like a Whipple's procedure, post-bypass surgery, Roxanne bypass or gastrectomy, you can think of using FJ feed. Otherwise, it is safer to give a feed through your gastric tube itself. Next question to answer is, should I give a continuous feed through a pump or should I give boluses? We don't take a continuous feed, no? We keep morning breakfast, lunch and dinner. We don't take often, right? So we all thought that it was wrong. Instead of giving continuous feed, we are unnecessarily tasking my patient with so much of volume. I will try to give a bolus therapy. So what happens when you give a bolus therapy? What happens when you give a continuous therapy? We needed an explanation for this thing. So what they found was they were giving a therapy by both bolus as well as continuous, and they were trying to assess what is happening with the small bowel water content. And second thing, what is happening with the superior mesenteric artery blood flow, and also they were looking at the plasma hormone concentration of the insulin at the level of the small bowel. What they found was continuous gastric feeding did not have any effect on the bowel volume. So it is safe to give continuous feed. You don't have to go and give boluses. You can continuously feed the patient. And there was no change in the small bowel blood flow as well as the superior mesenteric blood flow. And when you are giving the other way, you are giving boluses, this were changing. The small bowel water was increasing, the mesenteric blood flow was increasing, and similarly there was an increase in the small bowel superior mesenteric blood flow was increasing. So obviously it is telling us, instead of giving a bolus therapy, try to feed the patient continuously. That is more comfortable for the patient rather than a bolus therapy. And there was a lot of diarrheas in patients who were given bolus. Every 1 hour you go, take 50 ml saline, take your feed, you give it. What happened was there was a high small bowel content, and ultimately, most of the time when you are giving bolus therapy, during the first 72 hours, most of the patients had loose stools. That is one of the reasons why they were stopping bolus therapy and they went off for the continuous therapy. And which one had a better glycemic control? So in an ICU, in addition to the ventilators and vasopressors, we are very much worried about the glucose. We always try to target the sugars to be less than 180 milligram. So what they found was, whenever you are using a continuous feed instead of a bolus therapy, we had a better control on your glucose control. So glucose more than 180 has been implicated as one of the agents responsible for increased length of stay in hospital, increased stay in infection, as well as mortality. So we try to target it, and our therapy of continuous also helps to maintain my glucose control. So we need a comparison. So this is a randomized system in meta-analysis. They took all the studies and they tried to combine together, and they wanted to see what happens to my patient when the patient is given continuous or bolus therapy. What they found was the continuous therapy was better when it comes to mortality. Only complication which was seen with the continuous therapy was constipation. So if you are able to take care of the constipation part, these patients do very well with continuous therapy instead of a bolus therapy. There was no incidence of vomiting, there was no incidence of diarrhea, but constipation was there. So whenever you are giving a continuous therapy, try to give some small laxatives to keep the patient bowel free. And next is gastric residual. We are all worried. You go and give feed, you aspirate, some foreign will come, okay, my patient is gastric residual very high, I wouldn't want to feed the patient. So this was a very good study. They took about 450 patients, only on ventilator for 2 days, and they were trying to measure. What they found was whether they had a gastric residual or more than 300 or 400, there was no difference in your infection rate. So you don't have to worry about gastric residual volume. If you have a 400 ml, more than 400 ml every 4th hour, try to stop your feed, give some prokinetic, then restart it. If it's less than 200 ml, you don't have to bother. You just keep continuing giving your continuous feed therapy. And most important question is glutamine. All of us are very much, all the surgical surgeons, all of us physicians are very much interested in giving glutamine. They think that it's a very essential amino acids, especially when the patient is sick, we need to give them. We don't know whether the patient is safe with the glutamine and what are the recommendations for glutamine. So we think that physiologically, glutamine levels are going to drop whenever the patient has got to do a physical exercise, any major surgery or during critical illness. And similarly, whenever the glutamine level goes down, they are going to have an immune dysfunction, and that is going to contribute to mortality. So what they found was, they did a study by using the same component, glutamine with antioxidants. What they found was, those patients who are given glutamine, the mortality is high. So now we have come to the conclusion that there's no point giving glutamine for any of our sick patients. So glutamine and antioxidants in this study did not improve the clinical outcome, and that was highly associated to mortality, and they were also associated to multi-organ failure. So it is a warning sign, do not use glutamine in a patient when you are enterally feeding the patient. And next is very important topic. We always say that any patient having a colostomy or patient is having a resection anastomosis, they keep the patient NPO for 48 to 72 hours. So we wanted to do whether we can feed the patient within 24 hours of intensive surgery. This was a excellent article which came in 2009. So what they found was those patients who were given enteral nutrition within 24 hours of anastomosis, there was no anastomosis dehiscence, the mortality was also very less, and pneumonia was also less. I may be contradicting the surgeon's opinion, but our study, this meta-analysis very clearly showed that feeding the patient within 24 hours of an anastomosis will help for them faster recovery. The mortality is also low. So again, this is a take-home message to think that within 48 hours, try to feed the patient. So as I already told you, acute phase, you don't feed them very fast. You gradually go up on the calorie requirement. On day 1, you give 25%. Day 2, you give 50%. Day 3, go for 70%. During the next 5 days, you target the 100% calories. And on the post-ICU space, you target increase the calories by 125% of the predicted value and gradually go up on it. This is the take-home message when it comes to nutrition therapy in a critical patient. But what happens is, when the same patient goes to the ward, there are multiple factors which contribute to the nutrition drop-down. Like starting from patient factors, functional problems, and because of the health system factors, maybe we are not very good at feeding the patient in the wards. There are organizations and personal factors and psychological immobilities. A lot of this contributes to your patient's recovery being very less in the patients who are in the post-operative. That is where we need something called as nutrition stewardship program. Basically, this is to assess the intervention and monitoring which we can do at the bedside level. And it needs it's a multidisciplinary team. You cannot do by alone. You have to do multiple people do it, starting with the nurses, dietitians, physicians, pharmacists, administrators, biomedical specialists, occupational therapists, and speech language therapists. All these are involved when it comes to the nutritional stewardship program. And it's guidelines which has been given from all the societies. This is what we are going to do today. And the main purpose of the goal is basically we train them, educate them about the nutrition therapy. Then we develop a clinical nutrition guidelines which in the hospital we try to implement. And we try to see that these patients are not ending up malnutrition in their hospital. So, and most of the roles are like starting with your oral nutrition support, multidisciplinary interprofessional coalition, including your physician, clinician, nurses. This goes like a team. And a lot of hurdles are there when you're coming up, setting up a nutrition stewardship program in a hospital. So it starts from an outpatient clinic, preoperative as well as preparations, and it also includes the surgery anesthesia. The preoperative fitness, when they give anesthetists, that has to be taken care of. Whether my patient's nutrition has been optimized or not, then we go, patient goes for surgery, what happens in the continuous nursing unit when the patient comes to us, then what happens in the surgical ward, recovery, and home. It comes to home also. Even if the patient goes to the home, you keep on calling them whether you're taking the adequate nutrition which I have recommended you. This is what the nutrition stewardship program is. And what has been showed is, whenever the patient has been met with their energy and protein needs after the nutrition stewardship program, the percentage of complication has come down, as well as the percentage of mortality, length of stay in hospital has also come down. So with this, I'd like to end my talk saying that the therapy is always enteral nutrition. If you don't have any contraindication starting nutrition therapy, straight away go for enteral nutrition. Start slowly. After assessing the GA function, if the patient is not showing any signs of gastric intolerance, you gradually improve upon your enteral nutrition. Keep reassessing. What I said is continuous feed, so try to add some laxatives. If the patient is showing gastric intolerance, the patient is having vomiting, he is not tolerating a feed, you can stop the temporarily for some time, give some prokinetics, think of post-pulmonary feeding, and try to restart it. So the take-home message is very clear. Enteral nutrition is the therapy of need in the ICU as well as the post-op ward. Thank you so much.
Thank you, sir, for your insightful session. Now I request Dr. Sujit, sir, to have a conclusion remarks, also to present a small token of appreciation to our speaker.
Thank you, sir, for that very informative and crisp talk. A lot of take-home messages. And so things that stuck in our mind where one is the prevalence of malnutrition in our community. The patients may look well when you assess them, you find that they're malnourished. One. Second is the calorie intake starts slow and slowly build up. Same with the protein. Use enteral nutrition as much as possible. If possible, you can use oral. It's not that you can use FJ most of the time, and the importance of a nutritional stewardship program. Thank you so much, sir, for that wonderful talk. Let's give a big hand of applause.
So I invite Dr. Sujit sir to give a small token of appreciation. Please give him a round of applause. So now we move on to the formal inauguration of Nutrition Stewardship Program. To officially launch the program, I invite Dr. George Chandy sir to say a few words and inaugurate Nutrition Stewardship Program. So please.
I'll request Jyoti. അത് കഴിഞ്ഞിട്ട് inaugurate.
So want me to present it first and then so you need to present it first. എന്നോട് present ചെയ്യാൻ പറഞ്ഞു.
So I request Jyoti ma'am to give an overview of what this Nutrition Stewardship Program is.
Good morning, everyone. Thank you, Vijayanand sir, for the wonderful presentation. Nutrition Stewardship Program, why and what? It is a program which create the Center of Excellence in Nutrition Care, which includes a Nutrition Stewardship Program. It is a structured approach to nutrition care in the hospitals and healthcare settings, and which the main aim of the program is to improve the patient outcome, reduce the rate of malnutrition in the hospital, ensure evidence-based nutrition practices. So the objective of our program here is to early identification and management of malnutrition and nutrition-related complications, then develop a standardized nutrition protocol aligned with the national and international guidelines. So in the key components include the nutrition support team is the first component of that. Then the nutrition care process where the dietitian is usually assessing the patients. Then they are doing the evidence-based nutrition therapy and monitoring and outcome evaluation. So altogether it is called as a nutrition care process. And then we'll concentrate on education and training of the healthcare professionals and the patients. Then quality improvement and policy development. Later on I'll say about what policy development is. Then research and innovation. These are the 7 components of Nutrition Stewardship Program. So what is Nutrition Support Team? Nutrition Support Team is basically a team which contains a surgeon, intensivist or the physician who will initiate the nutrition support, and the dietitian is usually implementing the tools, assess the patient and give the nutrition support and monitor that. And the clinical pharmacist can monitor and manage the drug-nutrient interactions, and the nurse can edit and implement and adjust the nutrition delivery accordingly. So where we can do this nutrition stewardship program, we can do it in the ICU, in the post-operative, peri-operative cases, in surgery, and in all kind of surgery we can do it. But right now we are following the ERAS protocol in the GI surgery patients. So we can spread it over all the surgery departments. Then a ward it is possible in each ward, and then discharge and post-discharge patients also we can do this nutrition stewardship program. So basically what I wanted to tell you is we are actually focusing on the surgery patients right now. So we know that sir has already mentioned that almost 65% of surgical patients are already malnourished when they are going for surgery. So we have to tackle this issue, and also we as dietitians we give lot of proteins and calories initially, but we are able to provide only 22 to 36 gram. As per the guidelines are saying, like even though we give it, it will be around 36% of the estimated requirement. So how can we improve that level? Like how can we give more proteins is the option. Not only proteins but all the nutrients. By collaborating with the multidisciplinary team, we can be able to deliver better outcome in the patients. So, sir has already mentioned about the surgery patients. So, this is a meta-analysis where 97,000 of patients were taken for the surgery, and it was noticed that out of them, 33,000 were having sarcopenia. So, we know how much important nutrition is in a case of a surgery patient. So, sir has already mentioned about the journey of a surgical patient. So, where we have to intervene is in the OPD. We have to screen the patient in the OPD and assess the patient there, and we have to start it as early as possible. Like, as per the guideline, it is saying that we have to give pre-operative nutrition support before 1 month itself. So, along with oral nutritional supplements and immune nutrients, then the second part of it is pre-operative carb loading, where we are giving in IRAS protocol, we are giving the patients with 50 to 100 grams of carbohydrates in the form of maltodextrin or isotonic solution 12 hours prior to the surgery, and also 2 hours prior to the surgery. 2 hours prior to the surgery, we are giving around 25 to 50 grams of carbohydrates in 400 ml water. So, we have to concentrate on hydration as well as the carbohydrate level. So, then the post-operative phase where the patient will be admitted in the ICU. The sir has spoken about it very well, and we have to feed the patient. Sir has already mentioned that in the EP phase, we have to start with very slow rate of feeding. By third day, we can increase it up to 100% or 70%. So, in that, protein has to be given 1.5 to 2 gram per kilogram body weight. And most of us will stop it here. Actually, what we practice here is only that yellow part. So, when the patient comes to the ward, we will see the patient, we will assess the patient, and we will give the nutrition support. And in ICU also, we will give it. And when they go home, it is all nothing after that. So it is only very few part we are doing it. So we have to do it after they go home also. So we have to follow up the patients after they are going home also. So how we are planning to do it in the surgery is like, it is a very simple screening tool, that is a pre-operative nutrition score, which will be done from the OPD, where the patient will be, the first step of which is BMI will be assessed. If it is less than 18.5 for a normal person and less than 20 for a person who is 65 years or above. And the second step is if the patient had lost weight of 4.5 kg in the last 6 months without any trial. And the third step is if the patient is not eating less than 50% of the normal intake. If any yes to any of these questions, along with the albumin, if it is less than 3, then the patient has to be referred to the dietitian or the nutrition clinic. So then after that, we have to schedule the patient for the surgery. For that, what we should do, the POND score, if positive, we have to give high protein oral nutrition supplements for 4 weeks. Prior to surgery, we have to give for 4 weeks. Then perioperatively, before 7 days, we have to start the immune nutrients. What are the immune nutrients? Immune nutrients such as omega-3 fatty acids, arginine, or any other high protein supplement. If the patient is having vitamin D deficiency, it has to be corrected. Or if the patient has, maybe after the surgery, patient may be ending up in oxidative stress. So we can give more of antioxidants like vitamin C or E, and that kind of nutrition support, if required, we can provide that also within the first 7 days. Then I have already mentioned about the carb loading. It has to be given the pre-operative day. If tomorrow is the surgery, today we have to give pre-operative carb loading. Then if tomorrow morning 8 o'clock is the surgery, 2 hours prior to the surgery also we have to give carb loading. So, which will help the patient to make his anabolic state better, and which will end up the patient in a faster recovery. And then post-operatively, what we have to do is we have to continue the immune nutrition support for 7 days. After that, the 4 weeks we have to give oral nutritional supplement. I'm saying this as per the SPEN guidelines. So it is the protocol where the patient is identified as malnourished. And if the patient is not identified as malnourished also, we have to start the immune nutrients prior to the surgery. We have to carb load. It is not essential, it is as per the protocol of the hospital, but we can give carb loading also. Then post-operatively, we can give immune nutrients and can continue for high protein oral nutrition supplements for the next 4 weeks. So one more idea I have is with this nutrition stewardship program, we can develop a policy. Like as sir has already mentioned about glutamine. So I have a different, I'm not having different opinion, but I'm telling something like for a bone marrow transplantation patient or those patient who is undergoing chemotherapy presented with mucositis, whether we can develop a policy on glutamine supplementation. That is my idea. So it is an idea, it is not, not yet developed, but what we should do is with the support of the nutrition stewardship program, we can develop the protocol by including the nutrition support team. Then we can draft the protocol, we define the responsibilities to each of the members. Then we have to assess the patient nutritionally, we have to assess. Then implementation, we have to give the training to the team members. Then patient has to be selected, the dosing has to be fixed. We have the clinical pharmacists and the physicians and surgeons, they can fix the dosing. Then we have to do the initial implementation where we have to collect the data by monitoring the mucositis. Mucositis can be measured using the Nebraska scoring scale, and this is one idea. It is not, I'm just telling about how this can be implemented in our institution. Then later on, after assessing the mucositis level, we have to again nutritionally assess because of the mucositis, patient may not be eating anything. So after supplementing with glutamine, whether there is any difference in the intake of the patient and whether the nutritional status of the patient has improved or not, we can assess and we can update the policy based on this method. That is what I am expecting from this nutrition stewardship program. This is a simple example. So like that, we can do a lot of researches also. So the idea behind this nutrition stewardship program is to fill the gap in the hospital-based nutrition care practices and to improve the care of patients at risk of malnutrition or malnourished. Thank you so much for the kind listening. And thank you, sir, for coming. And I request you to inaugurate our nutrition stewardship program.
I think the important thing for us to remember is that there is a system that is followed in the country, which is political, which is to keep the ministers happy, to get votes. Attempts like this are holistic. Attempts like this are an effort to provide our people with what they need to receive. Patients are at the center of our activity. Unfortunately, doctors are at the center of most activities in the country. The IMA encourages that, everybody encourages. So for us to start something like this, even to think about something like this, means that we are thinking differently, we are thinking for the patients. So in order to have something like this, you need people. And we are privileged to have Jyoti, who is a pioneer in this field and is really working hard towards ensuring that our patients, that our people get what they merit, what they deserve, what they should be given. She's got that big appointment from the Public Service Commission and she chose to leave that and to continue here with us. So we are very privileged to have Jyoti staying on with us, building up a team. And I think many of us have started having the lunch that she provides. So slowly, Jomsi and all are losing weight a bit, little by little. But thank you. It's good to have people like you come and teach us and share with us. I'm grateful for your coming. And thank you, Abbott, for your support. So, what am I supposed to do? Basically, we are going to do in our institution something which nobody else has done in the country, which is patient centricity, patient centeredness. CMC Vellore heard about what we are doing, trying to do, and they've actually gone ahead of us there and introduced a song and a huge meeting for patient centeredness. Unfortunately, it was only a big function. After that, nothing has happened because my children work there. I realized that nothing has happened there. ഇവിടെ അങ്ങനെ പറ്റത്തില്ല. Here we have to make it happen. And this is definitely right at the heart of patient-centeredness. So thank you so much for this initiative. And we want to wish you all the very best. And I hope that this will make a huge change for our patients, for the treating team. Sujit, Philip and others have taken the lead with you, Jyoti. And we hope that this will become a routine practice for all of us. And having succeeded, we hope that we'll be able to translate this into something that the rest of the country can adopt. Thank you for this privilege. And this one. It's my proud privilege on behalf of all of you to inaugurate this new the Nutrition Stewardship Program.
At this outset, I would like to thank Dr. Vijayanand sir for coming here and delivering a wonderful speech on nutrition in critically ill patients. And I would like to thank Abbott Nutrition for their partnership with this program. And also I would like to thank Dr. Sujit sir for coming and moderating the session. And above all, I would like to thank George Chandy sir for coming and inaugurating all, this session and making it a wonderful success. And all the senior professors like JSK sir and Jomsi sir and all others, Dr. Philip Matthews sir from intensivist. We thank all of you from our bottom of our heart, and thank you very much for coming, all of you. Thank you.
We have arranged a small refreshment for everyone, so please do collect it.